Hello, my name's Mervin Singer. I'm at University College London, and it's a great, huge pleasure to be able to talk to you today. And I'd like just to cover antibiotics for sepsis, how fast and how long. And this is just a reminder of my little village, and the hospital is that tower block right there where the arrow is. I think it's fair to say, I don't know the exact figures for Ukraine, but it's likely, if you're similar to the rest of Eastern Europe, that you have a major problem with antimicrobial resistance. And this is sort of European surveillance data showing high levels of resistance to quinolones, to cephalosporins, to carbapenems. So there is a problem. The other thing I'd like to point out is that antibiotics are evil. They're nasty drugs. They impact negatively on the microbiome, immune function, mitochondria, organ function, and even actually reduce the effectiveness of chemotherapy drugs for cancer. So they're not without harm. However, they may be a necessary evil if the patient has a severe infection. So clearly, it's important to use them if it's obvious the patient has a treatable organism or if you're worried that they may have. However, it's no point giving an antibacterial if the infection's viral or if there is no infection present. So either don't start in the first place or stop early if you're confident it's not bacterial. There's been over the last 2 decades a push for giving sepsis or giving antibiotics very, very early for sepsis. Every second counts. However, as I'll demonstrate, this is largely based on propaganda, and propaganda isn't always truth. It's been recognised by the Surviving Sepsis campaign in their most recent 2021 guidelines that the quality of evidence for recommending antibiotics within an hour is low quality for septic shock and very low quality for sepsis without shock. So they still recommend giving it ideally within an hour. However, it is now a bit qualified over previous recommendations. So clearly, if you feel the patient has definite or probable sepsis, they recommend giving antibiotics immediately, ideally within 1 hour of recognition. On the other hand, if sepsis is possible and the patient is very sick, they still say give it antibiotics quickly. However, if the patient doesn't have shock and sepsis is just a possibility, then they say you have a 3-hour window to get some tests done and try and work out if it is a bacterial infection or not. However, the evidence shows that rushing in with antibiotics isn't actually of overall benefit. This is a prospective cluster randomized trial done in multiple centers in Germany, and they looked at the impact of delayed antibiotic treatment. And as you can see from the graph, some patients, it's a small number, but some patients didn't get their antibiotics started for up to 48 hours after admission. However, that is a minority, and clearly these patients weren't identified, were treated late, they have a worse outcome. But where you can see the red box, the first 6 hours, there's essentially no difference in outcome. And that's reflected by the figure on the right. If you look here, comparing outcomes in antibiotic-treated patients within the first hour, there's no difference in mortality risk until you get beyond 6 hours. Source control, good source control, is, however, very important, and that shouldn't be forgotten. This was a study that came out of New York, again a retrospective study, again suggesting that every hour counts. However, when you look at the supplement, they looked at, this is a database of about 50,000 patients, only the patients who needed vasopressors, the shocked patients, had a benefit from early antibiotics. Every hour does count with these patients, but those who weren't on vasopressors, 2/3 of the patients, early antibiotics did not make a difference. And that was echoed in this paper, recently came out also from the United States, where they looked at databases of 273,000 patients with community onset sepsis. Half had antibiotics within a 3-hour window, half had antibiotics between 3 and 12 hours. And you can see from the figure that the patients who didn't have shock, there was no added benefit from giving antibiotics very early. However, there was a signal in the patients who did have shock. Whether it's because of the early antibiotics or it's a reflection of the patient being actively managed with fluid and drugs and ventilatory support, we don't know, but it makes the point that, the early management of the shocked patient can make a difference. I was involved with this consensus statement. It came out in the UK a few years ago from the Academy of Medical Royal Colleges, and rather than going for a shock, no shock criteria, we're using what's commonly used in the UK, the NEWS2 score, the National Early Warning Score. And there's a paediatric version called PEWS, Pediatric Early Warning Score. And this is a score that's used for any sick patient. Increasingly, it's now used across the UK in emergency departments, in wards. Paramedics are using it, in ambulances, nursing homes are using it. Increasingly, general practitioners are using it. And so it's an easy bedside score, 7 variables, and essentially the more abnormal the physiology, the more points the patient gets. And so depending on how many points they score, that prompts the urgency for intervention. So if they score 7 points or above, that puts them at high risk of deterioration, of dying, and so that warrants an emergency response. So a senior doctor needs to see them within 30 minutes. For the less sick patients, there's more time, so you don't need to rush as much for those patients. And we've banded the NEWS score into low risk, green, medium risk going from yellow to orange, and then a high risk patient who scores 7 or above. And clearly you can push a patient up a band, so you can go from yellow to orange if there is a risk factor, for example, they're immunocompromised, or if there's evidence that there's an organ dysfunction problem, they have a high lactate, etc. So you can use the physiology and other evidence of clinical deterioration. It's also important to make sure that this is what the patient wants. It's very easy to put them on a pathway doing everything, and yet the patient may be nearing end of life. They've got end-stage cancer or they've got severe comorbidities. And so it's important to engage with the patient and find out how much sort of treatment intensity they want and what are their end-of-life care wishes. And we've divided the bands into the 4 bands, and that dictates how fast you need to respond. So if you're going to give an antibiotic within the red zone, 7 points or more, that should be done within an hour. You have a 3-hour window for those in the 5 to 6 NEWS score, a 6-hour window for those in the 1 to 4 range. And that's a maximum. So clearly, if once you make the decision to give an antibiotic, there shouldn't be delay. However, you have more time to think about what the likely diagnosis is. Is it bacterial? You've got time for a few tests, some imaging, perhaps talk to a microbiologist and so forth. So in the less sick patient, you have a bit more time to try and work out what your best course of action is. The very sick patients, you need to jump more promptly. And I won't go through the rest of this, but it's important to also remember things like source control. If you're worried that there is a surgical pathology, contact the surgeon early. And the point is not to delay treatment, but to give sufficient time to have an informed clinical judgment as to what to do. You've got to reach this balance between patient safety. You want to do the best thing for the individual, but at the same time, you don't want to keep throwing antibiotics around, because that will only make the problem of treating infection worse with high resistance rates. And as I mentioned, antibiotics themselves have problems, and I'll talk about this later on. Just to show you, this is some work I've been doing with some colleagues in Boston in the United States. This is looking at databases of 100,000 patients who had a diagnosis of infection or sepsis. And you can see, again, as I showed you before, the patients with shock, about 5,000 of them, they're the ones that benefited from the early antibiotics. Every hour does seem to count in these patients, whereas over the first 6 hours, there was no difference in early versus a little bit of delayed antibiotics in the no-shock group. This was reflected in the news score, and this was the basic physiology score, and as I mentioned earlier, you could add an extra point if they had a high lactate, or they were neutropenic, or there was evidence of organ dysfunction, new organ dysfunction. And you can see, again, patients with a new score of 0, 1 to 4, or 5 to 6 didn't have a benefit from very early antibiotics within that 6-hour period. However, those with a score of 7 or more did have that benefit. Interestingly, if you look right down the bottom, the patients who had a high new score, 7 or above, but didn't have shock, also benefited from the antibiotics, whereas those who were shocked but their new score was below 7 didn't have that early antibiotics outcome benefit. So it does seem that the new score is more sensitive in showing which patients will benefit from early antibiotics. So to summarize this part of the talk, the y-axis talks about the certainty of bacterial infection, the x-axis talks about illness severity. So in terms of antibiotic timing, if the patient is not very ill, they have a low new score, and you're fairly confident they don't have a bacterial infection, you don't need to give them an antibiotic. You can wait, you can watch, you can observe. If need be, you can do some tests. On the other hand, if they're very sick and you're sure it is a bacterial infection or highly probable, then those are the patients you jump in quickly with your empiric antibiotic regimen within 1 hour. On the other hand, if there's a low risk of infection, but you're fairly sure, a low illness severity, but you're fairly sure that they do have an infection, again, think, what could the likely bug be? Run some tests, seek advice, and you have more time. You have this 6-hour window to decide, but once you've made that decision, don't then delay giving antibiotics. For the patients in the middle, you have this 3-hour window where you can try and work out if I need to treat and what the best antibiotic regimen should be. And finally, if the patient is very ill, there's a slight chance they may have a bacterial infection, but you are worried, then it's reasonable to jump in early. So the message is timely, but not rushed. Let's move on now to the second half of the talk. How long should a course of antibiotics be? I think we have to blame the Emperor Constantine. So he essentially brought Christianity to the world, and what he did was decree a 7-day week. And we give a week's course of antibiotics, a 7-day week. So had it not been for Constantine, we might be using an 8-day week, which is what the Romans did, or a 10-day week, which is what the Egyptians operated upon. So why do we give 7 days? I think because it's a convenient number. 7 days, 14, 21. There's no clear rationale for why 7 days is picked other than its convenience. And there is this, I think, mistaken belief that, especially if you have a resistant organism, you need to treat for longer. If the antibiotic's going to work, in my opinion, it's going to work relatively quickly, and so a prolonged course of antibiotic is only needed when there's a deep-seated infection, an osteomyelitis, an endocarditis, and so forth. For a relatively uncomplicated infection, a short course is sufficient. How short is short? Again, we'll touch upon this. But just to show you that the evidence base is demonstrating that you don't need to give these very long 14, 21-day courses. I'll show you a number of studies in different infectious conditions. So the patient has a bacteremia. This is a big study that came out recently in the New England Journal, 3,600 patients, 74 hospitals, 7 countries, and there was no difference between 7 and 14 days in terms of outcome. Didn't matter if they were in the hospital or the ICU when they developed the bacteremia, or from the community. Didn't matter on whether it was gram-negative, gram-positive, polymicrobial. There was no added benefit from a long course of antibiotics. Even patients with Staphylococcus aureus, there's this fear that you need to carry on for a long time. But in uncomplicated Staph aureus bacteremia, get rid of the source. So, for example, if it's related to a catheter, a cannula, remove it. This study showed, it was a retrospective study, that there was no difference in outcome if the treatment was 7 days or less compared to more than 15 days. There was no difference in the rate of relapse of a deep-seated infection. And similarly, other studies have shown the same. So these authors recommended that you can routinely just use 7-day treatment regimens for uncomplicated Staphylococcus aureus bacteremia. What about meningitis? A big study in children in the Lancet in 2011 showed that 5 days was equivalent to 10 days. There was no difference in relapse rate, mortality rate, long-term complications such as deafness or neurological deficits. There was no difference if you gave a shorter course versus a longer course. And this was across the board for the main types of bugs, bacteria causing meningitis, so pneumococcus, haemophilus, and meningococcus. Interestingly, this is an observational study from New Zealand where they looked at patients with meningococcal disease. So a lot had meningitis, 21% had septic shock. There were 58 adult patients, and they found that 3 days was sufficient to adequately treat these patients. What about peritonitis? Again, the importance of good source control is something I need to emphasize, but this large multi-center trial from the United States showed that 4 days was as good as 8 days in terms of mortality risk and subsequent complications. For community-acquired pneumonia, there aren't many randomized studies. This is a registry study from Denmark where they looked at 1,150 patients admitted with a pneumonia who was stable at 3 days, and they found a short course treatment, a median of 6 days, was as good as a more prolonged treatment running for 9 days. What about those on a ventilator? Ventilator-associated pneumonia. This is an early French study comparing 8 and 15 days, showing no difference in mortality. However, they did show the longer course was associated with an increased risk of multi-resistant pathogens developing. This paper came out recently in Lancet Respiratory Medicine. It's a prospective trial, an open-label randomized trial in Nepal, Singapore and Thailand, 461 patients with a ventilator-associated pneumonia. And they had a short course, on average 6 days of treatment, versus a longer course, a median of 14 days of treatment. And in terms of outcome, again, no difference. But what they did find was those who had a longer course of antibiotics were much, much more likely to have an acute kidney injury. There was a 7-fold increased risk. And any antibiotic side effect, again, a big increase, a 4-fold, 5-fold increase in risk in those who had a prolonged course of antibiotic. The final thing I'll talk about is, should you be using combination therapy? And by combination therapy, what I mean is more than one antibiotic directed against the same organism. I don't mean giving one antibiotic for gram-negative, one for gram-positive. These are 2 antibiotics to try and hit the same organism. And so, for example, aminoglycosides like gentamicin is often used in combination with a cephalosporin or a carbapenem, for example. This is an observational study from the Netherlands. There was a large number of patients were collected and in 2 hospitals, one that routinely used gentamicin and the others that didn't. So it was mono versus combination therapy, a real-world sort of study. And those who had gentamicin, there was an increased mortality risk, 23% versus 29%. But importantly, again, the risk of renal failure was much greater in those who received gentamicin compared to those that didn't. This is also an interesting study from the United States. It was, again, observational from 4 intensive care units, and they followed, in some patients, the recommendations from the Infectious Disease Society of America, the American Thoracic Society, about giving antibiotics for multi-drug resistant pneumonia, community-acquired, hospital-acquired, ventilator-acquired pneumonia. And they had 303 patients. So the recommendations were to give dual cover for a gram-negative, so combination therapy for gram-negative, and to cover MRSA, methicillin-resistant Staph aureus, in addition. And they found that where there were pathogens identified, the compliance rates were about 80 to 85%, so not too bad. Interestingly, if you look at the results, those patients, about 40% where the guidelines were followed, had a much worse survival than those where they didn't follow the guidelines and only gave monotherapy. So you look at the survival rate at day 28, it was 79% survival where they didn't follow the rules and 65% if they did. So there was a worse outcome with multiple antibiotic therapy. So in summary, I think antibiotics represent an important part of our treatment. However, we've got to be careful as to how we use them. The positive impact on outcomes by treating the infection may be counterbalanced by potential harmful consequences. So yes, it's important to use them, but use them appropriately, use them sparingly, don't go on for too long. I thank you very much indeed for listening. Thank you.